Thank you for purchasing this product of patient presentation. So what's the purpose of this patient presentation? This is kind of like an intro course. This is like the training wheels version. This is what I'm working on. Basically, I'm trying to build it as it's flying, right? That's what I'm trying to do. So my whole problem, okay, is I tend to overcomplicate things. So I want to have this whole thing built out and all the technology and everything, whereas I just really need to see from you if this is going to work in your practice. So what you're going to find below is, once you finish watching this video, you're going to see 3 presentations. They're basically PowerPoints. One's on plantar fasciitis, one's on Achilles tendinitis, and the other one is my pre-surgical discussion. What my ask is of you is that you would kind of watch each section, and I made them only open one at a time. Basically, I think if we have everything, we don't do anything, but if you just kind of do these one at a time, going through, look at the PowerPoints, there's going to be a video explanation of how to do it. And then once you finish that, or at any time, please either send me an email, send me a WhatsApp. I'll give you my cell phone. When you have some time, you want to talk about it, and any questions you have, if it doesn't make sense, how to set it up, how to use it in your practice, things like that. I want to tell you a little backstory behind it. The reason I started doing these was basically because I got sued, and I didn't have a really good pre-surgical discussion. So that was the first one that I made, and it like made that pre-surgical discussion so much easier. Okay. And I'm like, wow, it was so much easier. I had everything there. And then I was thinking, well, what's really complex for me are like plantar fasciitis and Achilles tendinitis. And that's where those become the other ones. So that's kind of the backstory. And it's made my life so much easier. And I can do so much more like shockwave, so much more, so many more orthotics, just because it's all explained and there's those checklists. So once again, my ask is, after doing this, I want some feedback from you on each section. You know, you can critique the slides and things like that, but you can download those slides and edit them however you want, and then upload them up to Google Slides, or however you want to do it. And then I want to instruct you on how to kind of start using them, how to fit it into your workflow as a doctor. And then once again, this is just a concept, a proof concept. And then I want to chat with you and see how it's doing. Now, if you find this wonderful, I'll be happy to share the other ones with you, but I don't want to overwhelm you with too many initially. And these are the ones I use like 90% of the time, are these 3. Once in a while, I'll add some of the other ones, but start with these. Get your feet wet. Talk a little bit about this. I'm kind of passionate about it. I'll tell you a little bit of the backstory. You may have, if you're a doctor watching this, you may be thinking, well, patient presentations, isn't that where I presented to the attending when I was in school? And that just means how we learn in medical school, presenting about a patient. This is a little bit different. We're going to talk about technology, ways to increase efficiency, patient satisfaction, and bottom line. So let's get right into it. What's the real problem? Well, the real problem is that explanations are very complex with patients. And especially, let's take something real simple that we do all the time, like plantar fasciitis for podiatrists. There's so many different types of treatments for that, and it becomes complex, not just the first time that someone's seeing you, but if they come back like for the 5th or the 6th time, it can be a challenge and cause frustration. There's too many treatment options just for that one diagnosis, for example. And then we have limited time, and that's really the main thing. If you start and you see a patient, let's say you're seeing multiple plantar fasciitis patients in a day, and if you do a presentation, or if you talk to them about it, you look at the x-rays, you'll watch them walk, you'll do all those types of things. But ultimately, you give them the amount of time that you have, don't you? If you got 5 minutes, they're going to get the 5-minute explanation. If you have 30 minutes, you're going to get the 30-minute explanation. And if you really want to give them the amount of time they deserve, you're always going to be running late. And that's the real problem. That's kind of how I came up with this idea of patient presentations. And what makes it worse is the fear of litigation. So if you don't have everything documented the right way, if you don't go into everything in the right way, it can be a challenge. You have some needs. You have to get good reviews, meaning patients have to like you when they're being seen by you, and you have to try to finish all of this while you're doing documentation in the treatment room. Okay, how do you do all of that? I'm going to give you guys an idea that's been working for me, might work for you. I'll tell you a little bit about it.
Hello, Dr. Pelto here. I want to go over a little bit about Achilles tendinitis. This is for you if you are dealing with pain in the back of the heel. And I'm making this for you if you're one of my patients in the office. You're going to be watching this during our treatment process, or if you are watching it before, it's even a little bit better. So let's get right into this. What is Achilles tendonitis? The two most common types of Achilles tendonitis that I see in the office are, there is one that can be found at the back of the heel, okay, which is right here at the insertion point, and there's one that's slightly above it. The main difference is the one that's above it, it has this actual thickening of the Achilles tendon, where it actually gets little micro tears in there, and that can be very painful for patients when they're running, things like that. This is the typical area that gets broken or ruptured with a Achilles tendon tear. The other type, which is actually a little bit more challenging, is the one that is at the insertion level. So this is going to be a brief video to go into details, and I'll show you. And that's the whole challenge with dealing with these conditions, is they become chronically inflamed, or they have tendinosis or tendinitis, or they have little areas that just can't heal on their own. I think it's important when you come into an office and see someone, how long have you had symptoms? If you come in sooner, it's a little bit quicker for helping you with it. If it's been 3 months or longer, or a year or two, that's important as well. And also the treatments. What have you tried before? I always like my patients to try as many as they can before they come in. And in the last slide, you're going to find I'm going to give you everything that you can try even before you see a provider, just to make it more useful. What I find is the more you try prior, the less you have to do actually in the first visit. And then into some of the anatomy behind it, but basically in the back of the calf, you have the gastroc and the soleus, and both of those kind of unite into the Achilles tendon. And these form, and they actually cross the ankle joint right here, and then the gastroc specifically crosses the knee joint. Therefore, the ankle and knee positions are very critical. So if these ankle positions are off, if you're flattening in quite a bit, or if your knee is going in, this can really affect the Achilles tendon. And also you have here the hamstring, which tones the gastroc and therefore adds tension to the Achilles. So if you're tight up here and even up here in the core, that's going to be really important. Once again, I don't primarily deal with this, but I do refer out for physical therapy. And everything that's involved in posture can affect. So if you have tightness in different areas in your body, this can all affect the Achilles. A lot of times the problem isn't the Achilles, the problem is how you're moving over your foot. And there is something specifically called anterior pelvic tilt. Right here, you can tell this in the pelvis. When things are off or tilted forward, you can see here that the muscles in the front become short and tight, and the ones in the back become long and taut and weakened. And this can affect the Achilles tendon and everything else, causing lower back pain and other types of pain. These are all focusing on the Achilles. And there's a law called Wolff's Law, where the bone actually forms in the direction that there's pulling. So this just indicates there's pulling here and there's pulling here, but that doesn't always indicate that there's going to be pain.
I'm Dr. Donald Pelto, and we're going to talk today about this patient. You see here on the bottom of his foot, he has kind of some skin sloughing right here, and he has these little red dots around that area. So this patient, he came in, and he actually didn't know he had this. He had diabetes, and he had kind of this shiny skin with this problem. And you can see the skin looks normal in the arch, but down here on the bottom, it's all sloughy and kind of red and scaling. What this is called is athlete's foot, or tinea pedis. And with this type of a condition, it can cause problems because the skin can slough off, and there can be itching and different types of problems. And how do you treat this? Well, most people, they try
tonight, and you'll be able to see this at a later recording or later date as well. We're here to talk about arthritis, and arthritis is an extremely common problem that we see every day. And when we see arthritis, or when our patients come in with arthritis in their feet, they're complaining of symptoms. But that is not when arthritis begins. Most people equate arthritis to pain, and arthritis and pain are not the same thing. You can have arthritic joints that you have no awareness of, and you can have arthritic joints that are really painful. We're obviously seeing the people that are having pain or having issues from arthritis. Arthritis you can have swelling, you can not have swelling. You can have bone spurs, which occur when two joints sort of rub together in a way that they're not designed to rub together, and bone sort of builds up because of extra pressure that happens in people's spines, hips, ankles, and all of the foot joints. Some of the older people might see it in their knuckles too, with their knuckles enlarging. Those are all types of what's called osteoarthritis. Then there's a whole other group of arthritic problems, which are systemic arthritic conditions such as rheumatoid arthritis, lupus, gout would be a systemic arthritis. There's many different types: scleroderma, Sjogren's disease, Reiter's disease. There's Paget's disease. There's many conditions that can affect us systemically as well. We are born with everything needed to be a fully functioning adult. We are born without shoes. We are born without support underneath our feet, and it's a really important thing to understand that we have all the tools necessary to succeed in life from how we start. If you have a knee problem or a hip problem or a shoulder problem and you go to a doctor, they're going to send you to a physical therapist maybe, and the physical therapist is like, well, we need to support these structures, so let's strengthen the muscles surrounding to get you better. But if it's a foot problem and you go to a foot doctor or you go to a therapist or you go to a shoe store, they're going to say, well, let's get you into a new shoe or let's give you more support. Why not strengthen the foot? Why not strengthen the arch? Why not allow the foot to actually be a little bit more able to do the job that you're asking it to do? But again, it's really important to understand kind of where we start and where we're at now, because at some point between this and between where all of us are at now in our lives, something changed.
My symptom line.
So anything over this line, you're going to feel symptoms. We'll call it pain. Anything below the line, you're going to be blissfully ignorant of anything that might be wrong with you. So we like blissful ignorance here. We like you to have problems but not know about problems. It'd be best if you didn't have any problems, but we're all going to have problems because we all live a life and we're active and we do things that are probably not advantageous. We're going to wear shoes because we want to wear shoes, because we have to wear shoes, especially living in New England, but we want to look a certain way. We're going to have injuries along the way. We're going to live life. We're going to sit. We have to sit. We're going to do things that are problematic. So understand that dysfunction is going to happen, but our goal is to get you to help get them below. And again, we're going to go over that with you, and we're going to do the best we can to help you.
To start, I want to define regenerative medicine, but I would ask either of the doctors to contribute as well. Regenerative medicine is a game-changing area of medicine that can help heal damaged tissue and organs for people that thought their conditions were beyond repair. One aspect of this regenerative medicine involves boosting the body's natural ability to heal itself. For example, if you get a cut on your finger, it will usually heal in a few days. However, other tissue, for example, on the bottom of your foot, if you're a diabetic, can be slow healing. Using a specially engineered covering on the wound can boost your body's natural healing process for this wound. Here's a picture of this type of a graft that is used on a foot wound. Another type of regenerative medicine involves replacing damaged tissue or
Platelet-rich plasma is also called PRP, and it's taken from your own body. We would draw blood from your arm, most likely your arm, and there's a centrifuge that we have in the office, and it'll get spun down. Plasma is your blood taken out of your body and spun so the red blood cells are separated out. The red blood cells are heavier, so they end up at the bottom of the test tube. And there's a yellow liquid. It's the blood components without the red blood cells that has, it's called plasma. And inside of that is a larger concentration of platelets. We take that and then we'll inject it into the diseased tissue, and the tissue being tendon, fascia, ligaments, or joints, or even bone for that matter.
And so with this platelet-rich plasma that you get, does everyone, if you take it from me and from Dr. Saviet and from yourself, are we all going to get the same amount and same quality of platelets?
No, it's going to depend on your body. Yeah, and in today's day and age, people are very leery about chemicals being put into them or anything that's going to be damaging or toxic to the body. Cortisone is wonderful. It's an anti-inflammatory, so it stops the inflammatory process. It can help reduce localized inflammation, and it can help with symptoms. There's no doubt about it. The problem is it also delays natural healing. It actually interferes with the body's natural healing response. Platelets are what promote the body's healing response. We want platelets to be tissue going in, but we can do the same thing with platelet-rich plasma, or PRP. So it's any of the tissues you need it to go into, we can put it into those tissues.
And is this something that's done in the operating room? Is it something that's done in your office? And what's the recovery like afterwards? Do you have to be out of work?
Yeah, you can do it anywhere. We actually do it right in our office. We have the ultrasound machine in our office. MRIs are typically the gold standard diagnostic study where you can see tissue disease. You can see tears in tendon, you can see splits, you can see inflammation, you can see cracks in bone. But the diagnostic ultrasound gives you real-time imaging capabilities, and we have it in our office, so you can do it right in the office. It's a blood draw. The spin on the centrifuge is about 5 minutes. So the blood draw, it's me drawing the blood. So if you're an easy stick, it's pretty quick. Sometimes it takes a little longer if you have a difficult vein. The spin itself is about 5 minutes. Sometimes we'll use a local anesthetic to the area to limit any discomfort that might occur from injecting it. PRP, which, as you mentioned, we call it liquid gold because it's a golden color, and that gets injected into the areas. So if there's larger defects, that's a really nice option to have. The procedure itself takes, if we're doing it under ultrasound, it might take a little longer, but from 30 seconds to 3 minutes. Afterwards, you get a Band-Aid or a soft wrap. Depending on the structure involved, you might go into a soft cast and a walking boot for up to 2 weeks, and you're walking out.
That's what it is.
You might need a ride if it's your right foot, because you might need to be in a walking boot on your right foot.
And is there anything you can't do after? Can you take Motrin, ibuprofen, things like that?